Hi guys, welcome back again. Today I'm going to talk to you about another medical topic, which is pleural effusion. First of all, let's focus on the term pleural effusion. Pleural refers to a space between chest cavity and lungs, while effusion refers to a collection of fluid. So pleural effusion is when disease process causes accumulation of fluid in the pleural space. While as you know, pleural are a thin membrane lining the lungs and inside the chest cavity act to lubricate and facilitate breathing. Besides pleural effusion, we have empyema and hemothorax. Empyema means accumulation of pus, while hemothorax is derived from hemo, which is blood, and thorax, which is chest. So hemothorax is accumulation of blood within the pleural cavity. Okay, let's jump to mechanism of pleural effusion, which is accumulation of fluid in the pleural cavity. So by increase hydrostatic pressure, decrease osmotic pressure, decrease pressure in the pleural cavity, permeability in the microvascular circulation, and decrease lymphatic drainage. Let's turn to know causes of pleural effusion. We can divide it into bilateral pleural effusion and unilateral pleural effusion. Bilateral pleural effusion, we can which also subdivided into common and uncommon. Common causes of bilateral pleural effusion include cardiac failure and pulmonary infarction, while uncommon include connective tissue disease like systemic lupus erythematosus, SLE, and rheumatoid arthritis, hypoproteinemia, myxedema, and uremia. While unilateral pleural effusion is also subdivided into common and uncommon. Common include pneumonia, TB, malignancy, and subdiaphragmatic disorder like pancreatitis, while uncommon include post-MI and acute rheumatic fever. Now let's talk about clinical assessment of the pleural effusion. SOB, shortness of breath, is the only symptoms related to the effusion itself, and the severity depend on the amount of fluid. While symptoms of pleurisy like pleuritic chest pain and pleural rot often precede the development of an effusion. So now, what about physical finding in a case of pleural effusion? Tachypnea in inspection, while in palpation we have decreased chest expansion and tracheal shift to other side in large effusion. The fourth one is stony dullness on percussion. The fifth one is on auscultation, absent breath sound and vocal resonance, and crackle above large effusion. Now let's talk about investigations of a patient with pleural effusion. We have chest x-ray and ultrasound. Chest x-ray around 200 ml of fluid is required in order to be detectable on PA chest x-ray, and blunting the costophrenic angle and curved shadow at lung base with elevated hemidiaphragm, while ultrasound is more accurate than chest x-ray. And about pleural aspiration, at least 15 ml should be aspirated and sent for protein, white blood cell, and Zell-Nielsen stain, ZN stain, and a culture for TB, because TB pleural effusion adenosine deaminase more than 40 international units per liter can be diagnosed. As you know, there are a lot of causes of pleural effusion. One of them is TB, tuberculosis. The type of fluid of TB pleural effusion is exudate, while in, for example, cardiac failure is transudate. A low pH suggests infection, but may be seen in rheumatoid arthritis. Pleural effusion, we have an important point. We have to put it in our mind, which is Light's criteria. So what's Light's criteria for distinguishing pleural transudate from exudate? So according to this criteria, it's likely to be exudative if one or more of the following criteria are met. First of all, we have pleural fluid the ratio of pleural fluid protein and serum protein greater than 0.5. The second one is the ratio of pleural fluid LDH and serum LDH greater than 0.6. And the third one is pleural fluid LDH greater than 2/3 times of upper limit normal serum LDH. And in other hand, we have pleural biopsy is helpful for diagnosis of malignant pleural effusion and TB effusion also. And then we have thoracoscopy. More than 90% can diagnose malignancy and more than 95% can diagnose TB also. And then we have thoracosynthesis is performed if clinically and radiological diagnosis isn't possible. And about management, therapeutic aspiration can be required to palliate shortness of breath. And that's all about pleural effusion in general that I mentioned in this video. Thank you for watching this video, and don't forget to make dua.